Good afternoon. Thank you for joining Alabama Medicaid's ACHN webinar on provider quality measures, bonus methodology, and attribution. My name is Melanie Cleveland, Director of Communications with Alabama Medicaid. The purpose of today's webinar is to provide you with an overview of the new ACHN changes effective October the 1st of 2024. I would like to introduce our speakers today. We have Connie Fales, the Senior Analyst of Quality Analytics at Alabama Medicaid. And we have ACHN, the Manager of Quality Analytics in Alabama Medicaid Agency as well. They will both give a brief presentation. Before we get started, I have some housekeeping items I would like to go over. First, all participants who have joined us by phone and through WebEx have been muted. Please do not unmute your phone or microphone during the presentation to avoid disrupting the presenter. Secondly, attendees have the opportunity to utilize the chat box function within WebEx to enter their questions, and they can also email questions to the achn@medicaid.alabama.gov email address. The program areas will review these questions and they will post responses on the ACHN provider's webpage. From www.medicaid.alabama.gov, you select the ACHN tab, and then you select ACHN providers from the drop-down menu. All webinars are being recorded for providers, and they will be posted on the Alabama Medicaid website under the ACHN Providers tab. Please record your attendance if you've not already done so by entering your name and the organization that you represent in the chat box at this time. If you've joined us by phone, you can record this attendance by emailing achn@medicaid.alabama.gov. And I will now turn it over to Connie Fales.
Thank you, Melanie. Today's objectives are to present the attribution overview, quality measures with descriptions and criteria, provider quality bonus methodology review with timelines and calculations. Attribution overview. Attribution is the process that will be used to associate a Medicaid recipient to the PCP group that provides primary care to the recipient. PCP groups must sign 2 agreements, one with Medicaid and one with the ACHN entity to participate. Under the ACHN program, Medicaid recipients will be attributed to PCP groups based on historical claims data utilization. PCPs are encouraged to continue seeing patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining distribution of bonus payments among eligible providers. Guidelines, guiding principles of attribution methodology, consistency with ACHN's principles of paying for activity, continued emphasis on care coordination and health outcomes with a focus on preventive care, acknowledgement that some recipients require specialist care, and evaluation of activities at the PCP group level. Key steps in attribution. Medicaid recipients that have met criteria for the ACHN program for 3 out of the previous 24 months will be attributed. This does not have to be a continuous period. The 2-year history of face-to-face provider visits goes as follows. Both preventive visits and regular office visits are scored. Preventive visits receive a higher point value. Recent visits are scored higher than older visits. PCP visits receive a higher point value than specialist visits. Also, the previous 12-month history of field prescriptions for chronic conditions are scored. The attribution process. On a quarterly basis, the Medicaid agency will determine attribution for each Medicaid recipient under the ACHN program in accordance to the following process. Point values for face-to-face visits will be assigned to the individual provider that performed the service. Also, as a part of the attribution process, the individual PCP scores will be combined to form the PCP group's total point score for each patient. The PCP group with the highest number of points will have the Medicaid recipient attributed to that PCP group. If a specialist group has the highest number of points, then the specialist group will be attributed the Medicaid recipient. Now let's look at quality measure specifications, some guiding principles for quality measures. Department of Health and Human Services, HHS, identifies metrics that pertain to preventive services, treatment, and management of medical conditions. The Centers for Medicare and Medicaid Services, CMS, collects quality measure data from all 50 states in an effort to strengthen quality of care and health outcomes. Specifications for adult and child core set measures are released annually by HHS. All measures are nationally validated and have standard specifications. The ACHN benchmarks are developed based on quality measure rates as reported by the various states, and then we adjust those as necessary. Claims data. Quality measure rates are calculated using the administrative claims data providers submit to the agency. We also utilize data from other state agencies when applicable. Measures will be evaluated by a third-party external quality review organization, and bonus payments will be awarded based on providers attaining predetermined targets. Statewide baselines are the calculated quality measure rates for the contract period based on previous year's statewide performance. Statewide benchmarks are target rates set for providers to meet annually. Providers have one target per measure to meet quarterly. Provider quality measures, there are a total of 8 measures. There are 5 child measures and 3 adult measures selected to assess provider quality performance. The 5 child quality measures are listed here, and it includes their abbreviated name. Chlamydia screening in women ages 16 to 20. Rates include CPT code 87801. This code is included in order to comply with Medicaid's policy about STI battery of tests when testing for multiple STIs in one visit. Childhood immunization status, combo 3, DTaP, IPV, MMR, HIB, Hep B, VZV, and PCV vaccines make up combo 3. The unabbreviated names are listed in the measure specifications, and we will direct you to those shortly. Child and adolescent WellCare visits, ages 3 to 11, and child and adolescent WellCare visits, ages 12 to 17. Measures and targets. So we'll review the child measures and then we'll look at the adult measures. CHAO, chlamydia screening in women. A rate includes CPT code 87801. This measure is described as percentage of women ages 16 to 20 who were identified as sexually active and who had at least one test for chlamydia during the measurement year. The statewide baseline or average is 52.5%, and the statewide benchmark or the quarterly target is 56.7%. CISCH, childhood immunization status, combo 3, DTaP, IPV, MMR, HIB, Hep B, VZV, and PCV. This measure is described as percentage of children age 2 who had specific vaccines by their second birthday. The statewide baseline or average is 65.5%. The statewide benchmark or target is 67.6%. IMACH, immunizations for adolescents, Combo 2, meningococcal, Tdap, and HPV vaccines. This measure is described as the percentage of adolescent children age 13 who had specific vaccines by their 13th birthday. The statewide baseline is 39.9% and the statewide benchmark is 40.8%. WCV-CH1, child and adolescent well care visits ages 3 through 11, and part 2 is ages 12 to 17. This measure is described as percentage of children who had at least one comprehensive well care visit with a primary care practitioner, PCP, or an obstetrician gynecologist, OBGYN, during the measurement year. For ages 3 to 11, the baseline is 52.4 and the benchmark is 54.8. And for adolescents ages 12 to 17, the baseline is 46.5% and the benchmark is 49.6%. Next, we will review the provider quality measures for adults. Video screening in women ages 21 to 24. Rates include CPT 87801. And again, this code is included to comply with Medicaid's policy when testing for more than one STI in a visit. Hemoglobin A1C, control for patients with diabetes, HbA1c, control less than 8% for ages 18 to 75. Timeliness of postpartum care, visits that occurred between 7 and 84 days after delivery. CHLAD, chlamydia screening in women. This measure is described as percentage of women ages 21 to 24 who were identified as sexually active and who had at least one test for chlamydia during the measurement year. The statewide baseline or average is 63.4%. The statewide benchmark or target is 64.1%. HBD-AD, hemoglobin A1C control for patients with diabetes, HbA1c control less than 8%. This measure is described as the percentage of beneficiaries ages 18 to 75 with diabetes type 1 and type 2 whose hemoglobin A1c, HbA1c level was in control at less than 8%. The statewide baseline is 3.5% and the statewide benchmark is 10.5%. PPCAD, postpartum visits. This measure is described as percentage of deliveries of live births on or between October 8 of the year prior to the measurement year and October 7 of the measurement year, and had a postpartum visit on or between 7 and 84 days after delivery. Statewide baseline is 65.8 and the statewide benchmark is 69.2%. Resources, the quality measures will be posted to the Medicaid website this month, and we will send an update when they have been posted. And if you need them sooner, you can also find the measures at www.medicaid.gov. Again, that's www.medicaid.gov. And then you will click on Medicaid and then navigate to quality of care located on the left side of the screen, and then click on performance measurement. From there, you can select the child core set reporting resources or adult core set reporting resources. And then once you make your selection, then this is what you will see. And this is the child core set reporting resources. And the applicable manual or specifications are the FFY 2024 Child Measures Manual and Technical Specifications, and the same for the adult FFY 2024. And then there are other resources that you can download from this website as well that pertain to quality measures. And we will list the website in the responses that we'll send out as well for the questions that you have. This is a screenshot of the license agreement. When you click on one of those selections, you will be taken to this screen, and you will have to agree to this agreement. And then you scroll all the way down to the bottom and click accept. Next, we'll have XJ, who will show us about paying for quality.
Thank you, Connie. Good afternoon. My name is ACHN. I'm the manager in the analytical division. I will go over the next sections, paying for quality. In this, I will focus on the determination and the distribution of bonus payment for the quality metrics. As you can see in this slide, this is the PCP payment structure. All the physicians will receiving the base fee-for-service schedule. For the providers had participated with the regional ACHN entities, they will receiving the enhanced fee-for-service rates on certain procedure codes. And also the providers participating with ACHN entities are eligible to receiving 3 bonus payment quarterly based on the quality performance and the cost effectiveness scores and the status of the patient-centered medical home activities. All those 3 metrics also impacted by the attribution. This slide is showing the payment timelines. Starting with October 2024, as you can see, the highlights in each of the quarter, the first month of each quarter, that's where the bonus payment will be distributed. As I highlighted in here on the quality measured bonus, there is a 12-month data lag with 9 months rollout. The actual payment based on the data will be starting on the April 2026. So the first 6 payments, it will be based on the attribution, but the providers will still receiving the scorecard so they can see their progress towards the benchmark. The cost effectiveness and the PCMH bonus will based on the actual cost effectiveness scores and the PCMH status with the first payment in October 2024. Next. So in this slide, Dr. House has presented this in his talk last week. It's just showing you the bonus payments. The annual bonus payment is $15 million This will be divided by 4 quarters. So each quarter will have 3.75 million. But the agency will keep the $100,000 as a reserve pool. This will enable the agency to help offset bonus payment issues. But this reserve pool will be distributed in the fourth quarter. Any remaining funds will be distributed in the fourth quarter. So as you can see here, in each quarter, there are 3.65 million will be distributed for the 3 bonus I had just mentioned in the previous slides. So this is looking at how the 3.65 million distributed each quarter. 50% of this will be distributed based on the qualities. 45% will for the cost effectiveness, and 5% is for the PCMH recognitions. The cost effectiveness will be presented next week, so I'll be focused on the quality bonus payment. The PCP group will be eligible for a bonus payment if they meet the requirements as follows. For the first 6 quarter of the programs, all practice groups will automatically receive the quality bonus payment that is based solely on the number of attributed patients. Beginning April 2026, the group must achieve annual bonus benchmarks determined by the agency. The quality bonus will be based on the rolling 12-month data with 9 months rollout. If a denominator in a particular measure is less than 10, the measure will not be counted towards the quality score. The benchmark will be posted in the Medicaid website towards the end of this month. So starting this slide, we are going to walk through a step-by-step examples using a hypothetical provider, Gallagher Family Practice. Going through this process, there are 2 assumptions that will underlie each step in the process. So in the scenario I'm talking, the agency is estimated approximately 500,000 attributed members statewide. The actual total attributed members will change quarterly. The attribution to some or all provider groups may also change quarterly. There are 3 processes in this flow chart. I will talk each of them in the detail. The first process is member attribution. Second one is quality scoring. The third process is bonus payment determination and distribution. So I will go through one process at a time. Then I will stop at the end of the process with a flow chart and go through a more detailed numerical step-by-step scenarios. So as highlighted in the top rows within this blue frames, that's the first process, member attribution. Using the Gallagher Family Practice as the example, this practice has attributed members 6,300. The statewide attribution is 500,000. So the distribution rate of attributed member for this group is 6,300 divided by 500,000 is 1.26%. So next slide, that's showing this the numerical scenarios. So we are assuming there are 10 providers group. This is just for the illustration purpose. So as you can see here, the Gallagher is 6,300 members. The total members of all the 10 providers listed here is 500,000. So for the Gallagher is 1.26%. As you can see, each of the other groups listed here, because the member attribution is different, the distribution is different, but their total, the distribution will be 100%. Next step. This step was showing the quality scoring. In the step C, we will begin the quality scoring calculation. So again, we just assume there's assumptions here. On the step C, they were showing this particular groups had qualified for all 8 quality measures Connie had just mentioned earlier, but they only meet the benchmark in 5 of those. So they are having scores is 5 out of 8 is 62.5. The next step will be, no, go back please. For this steps below the step C, they're showing so the groups have to make at least 50% of applicable metrics. So 62.5 makes this group qualify for the bonus. If the group made less than 50%, then they will stop here. They're not going to be determined for the payment out. So this just move to the step D, the provider group qualify for the bonus payment. In step E and 5, we'll have to determine the distribution rate of attributed members. So again, you will see a little bit of more details in the next slide, but because not every group will meet for the qualities, so now the attributed members in the groups meeting the quality metrics minimums change to 359,000, down from 500,000. So again, the rates for this Gallagher groups is determined by 6,300 divided by 359,000. So it's 1.75%. Go to the next slide. This is showing how this is determined. So the Gallagher had made 5 quality measures out of the 8 possible. The quality scores is 62.5. They did meet the minimum, so their 603,000 will be counted towards the total attributions that meet quality minimums. Then the distribution rate is 1.75. As you can see, I highlighted in the group number 3. This one, the quality scores is 37.5. It's less than 50%. So those group is not meeting the minimum. They are not going to be considered for the following steps. So the last step is the bonus distribution. Have mentioned that earlier this group made the quality scores 62.5% with their the distribution rate is 1.75%. They make this bonus distribution rate is 1.1%. The quality scoring does matters in the steps. So the high quality scores you get, the more for this distribution rate it will be. Then we'll have to go through the next step is normalization. So that will enable 100% of the bonus pool being distributed to all the providers that had met the quality metrics minimum. in this case, there are total 74% of members in the qualified provider groups. So normalization, after the normalization, the bonus distribution rate for Gallagher's becomes 1.48% and up a little bit from 1.1%. Then to distribute that's 1.8 million, 1.48% is $27,000. This is the dollar amount will be distributed to the Gallagher practice for this quarter. So again, this is the showing the details on how this determines. As you can see, the distribution rate before the normalization is 1.1%. After the normalization is 1.48%. 1.48% out of 1.8 million is $27,000 that will be distributed to these groups. Thank you. This is the end of this presentation.
Okay, thank you, XJ. Thank you, Connie. As a reminder, this webinar was recorded and all of our webinars for providers are being posted on Alabama Medicaid's website. That's www.medicaid.alabama.gov. Click on the ACHN tab at the top of the screen and then select ACHN providers from the drop-down menu. You'll find the recording later today or possibly tomorrow morning. Also, we ask that you record your attendance. If you have not already done so, you can do that by typing your name and the organization you represent in the chat box. You can also email any questions that you have as well as your attendance to achn@medicaid.alabama.gov. We thank you again for your attendance and we hope you have a great afternoon.